Hi, welcome everybody. Great to see you. I can't believe we're at another webinar, and this one is going to be amazing. Procedural comfort in pediatric ophthalmology. Now, you may wonder, what is that about? It's something that's really important, and I've been really looking forward to this particular webinar. Mahatma Gandhi said, the future depends on what you do today, and I think what we're about to do today is going to change where we're at. Now, I realize that at the moment you're just looking at me, but I would like to share this with you. There's Mahatma Gandhi, and he said, the future depends on what you do today. Okay, we have a great panel of moderators. We've got Sandra Staffieri from Australia. She's the manager of the retinoblastoma service, research lead in ophthalmology at the Royal Children's Hospital of Melbourne. And she is a force of nature. I'm really looking forward to working with you today, Sandra. And we have Florien Pilon-Kamsteeg from the Netherlands. She's at the Bartimeus Diagnostic Center for Complex Visual Disorders. And she's CVI at the CVI Expert Center in Zeist. And I'm Kestrel. We do have two discussants. I'm very, very proud of them because, firstly, I know, Sandra, it's 1 a.m. in the morning where you are. Shelley, it's 1 a.m. where you are in Australia. And Shelley Hopkins has done a lot of work and is doing a lot of work, especially in the area of cycloplegic drops at the Centre for Vision and Eye Research at Queensland in Brisbane. But they're also looking at First Nation patients and how cultural differences can make a difference on how you can reduce anxiety. Now, Jagrat Lalu, I don't know if Jagrat is on at the moment. Jagrat is a fabulous optometrist. He's part of the International Myopia Institute, World Council of Optometry. He works at the University of Auckland and at the New Zealand Eye Research Centre. But it is 3 a.m. in the morning in New Zealand. So let's hope that let's hope that he's going to join us, but we won't hold it against him if he doesn't. So I'm going to hand you over now to Florien and ask Florien to introduce our speakers.
Yes, it's an honor to introduce two of our speakers. The first one is Dr. Hurdle. He's a retired pediatric ophthalmologist and a former investigator in the field of nystagmus, eye movement disorder, and strabismus. And we are very pleased to have him join us this webinar. He also brings extensive experience in public speaking and presenting. And the second speaker is Piet Leroy. Piet is a professor of procedural sedation in children and pediatric critical care specialist in the Maastricht University. And he really is my father in procedural comfort. I learned so much of him, and I'm very honored that he will join us today. I will now, Sandra?
Fantastic. Yeah, Sandra, go ahead.
Sure. Thanks, Florien. And it is my distinct pleasure to introduce Morgan Livingston from Toronto, Canada, who's a certified child life specialist. As a child life officer of World Eye Cancer Hope, which is how I actually met Morgan quite some years ago now, Morgan's taught me everything I know about child life and procedural comfort, and importantly, what I could do as an orthoptist to do better. Morgan writes and creates resources for children and adults. She established the Sally Test Child Life program in Kenya and developed an award-winning app for Operation Smile using virtual reality to prepare children for cleft lip and palate surgery. And I'm also very honoured to meet for the first time and introduce Dr. Nicola Freeman, consultant ophthalmologist in Cape Town, South Africa, and she's the head of Paediatric Ophthalmology Service at Groote Schuur Hospital, who has a special interest in procedural comfort, and she's going to provide a global perspective on challenges and solutions across various contexts.
Thank you so much. Sorry, thank you so much, Sandra. Before we start, I just want to go over some housekeeping rules. WSPOS welcomes and encourages questions from the audience. I have to tell you right now, we have listeners from India, Pakistan, the Netherlands, Argentina, United Kingdom, USA, and I've mentioned India already, and also now Bolivia. So it's a pretty global audience already. If you have questions, please type your questions in the YouTube comments section. Our moderators are closely monitoring the comments and they'll come to us. And should the moderators miss any questions, please email them after the webinar to admin@wspos.org, and we can then try and get some answers to you. The main thing is that you really enjoy this. I hope you enjoy this tremendously. And on that note, I am going to invite Sandra Staffieri to give our first presentation.
Thank you so much, Ken. I'm just going to set the scene, really, of how I, as a seasoned orthoptist, came to be faced with the realisation of the lifelong impact of what I do and how I do it as an orthoptist actually really matters. In 2019, I interviewed a 40-year-old woman in Denmark. We were going to talk about her experience as a third-generation retinoblastoma survivor. And when I asked her to talk about her experience, the first thing she wanted me to know was about the eye drops. And as an orthoptist, I too was guilty of this technique sometimes, decades of holding children down for eye drops they just needed to have. Given that installation of eye drops are absolutely critical for any comprehensive ophthalmic examination. And her words just really hit a nerve, and whether it was because I was in a position where I could stop and really listen and I was outside of my usual context, I don't know what it is because I don't think I'm that unfeeling, but it really gave me pause to think about what I do. And although she reassured me that as a clinician, we're forgiven, her words really stuck with me. And I was reminded that procedural anxiety can be lifelong, and the importance of reflecting on what we do and how we do it and how we actually might do it better. And although there is not a lot of literature specifically relating to procedural anxiety and eye drops, we do know that repeated invasive interventions can have a significantly negative and lifelong impact, and an anxious child becomes a forever anxious adult. Now, I've listened intently to parent and survivor perspectives over my number of years now involvement with World Eye Cancer Hope, and I've learnt much from child life therapists on how I can just do little things like changing my language, introducing comfort positions, and providing choices that a child can make. They can't make the choice of whether they have the drops or not necessarily, but they can choose how we go about achieving that goal. And I'd like to also applaud Ken Nischel and the Executive Board at WSPOS for acknowledging procedural comfort as being as important as treatment that we give in paediatric ophthalmology, which brings us here today. I'd now like to call upon Pete, who will present on managing procedural distress in children. Thank you, Pete.
Thank you for the kind introduction. I'm going to share my screen, and here it is. I hope you can see it all. So thank you for the invitation. This is my very, very first lecture that I might give or can give to people from the Paediatric Ophthalmology, have a background of Paediatric Ophthalmology. My field of work is trauma-free medical care in children, especially in the non-ophthalmology field, when it comes to needles and all kinds of other procedures in children. So what are we talking about, actually? I think we can all agree that modern pediatrics nowadays has a high quality of care. We are all focusing on lifelong learning, trying to improve our practices. We have excellent outcomes, but there is like a backside of this gold medal that we are so proud to speak about. And that gold medal is that we do a lot of things in children. And you see an example from my world, things that happens on the emergency room, nasogastric tubes, IV accesses, small wound care. And we used to call these things in pediatrics minor procedures because they are technically not complex, but for the child, they can be a significant burden. And we know from a lot of literature that this pain or fear that is associated with medical procedures, that it causes resistance. Children don't understand, they fight. So the procedure, there's the risk that it fails. So we use a kind of restraint. And as a result of that restraint, more pain and fear will start to exist. And then the consequences, as explained already by the previous lecture, is that it causes post-traumatic problems, post-traumatic stress disorders, but mainly, and that's for me the main problem, is that children just lose their trust in medicine. And what happens at the dentist might cause a problem for the ophthalmologist, and what happens with the ophthalmologist might cause a problem in the emergency room or for the next vaccination. So this whole cycle of events in children, especially chronically ill children, is really a problem. And what are the challenges actually? Let's focus a little bit on the challenges. The first thing is that children are so different. Just look here, these are vaccination pictures, all the same procedure, and you see all different responses in these children. They all bring their own competencies or their own fears or their own problems. And this is challenging for healthcare professionals who are actually not trained to deal with this. Second challenge is that children never come along alone, but they come with their parents. And for example, anxious parents might have a huge impact on how a child experiences a procedure. And next thing is that we know from literature, and if we dive into that central picture here, actually know from literature now that there is actually an empathic mismatch problem between the fear and the suffering of a child and how professionals behave. And this concept is called nowadays transient empathic blindness. Probably as a kind of coping strategy, professionals tend to close their heart, their mind, their eyes for the suffering in children, especially when the procedure is medically necessary. And finally, the way we have organized healthcare in children is often not taking care of negative information that children might experience. Like, for example, on this particular picture, if you look on the background there, this little kid waiting for the vaccination, what will she think when she comes on this chair and hear professionals telling to her, don't worry, everything will be safe. She will not believe it. We haven't organized healthcare in a way that we want to protect children for negative information. So actually my work that's supported by a Dutch society, Child Braveheart Society, together with my university, we created an expertise center in the Netherlands, which is now expanding to countries like Belgium, Scandinavian countries as well. And we created an expertise and training center that wants to understand what is actually procedural distress all about and what skills and competencies do professionals need to deal with this big challenge. And we call that kind of care trauma-free care or PROSA care. And it means that in all parts of the caring process, minimizing pain and anxiety and avoiding trauma are just as important as managing the illness itself. So PROSA care actually ensures that procedures are successful and comfortable, and children and parents maintain their trust in healthcare providers, the care, and in themselves. And that's important. So it's actually like a new paradigm in healthcare. Let's check this. Yes, there we are. So this is, for example, an example of trauma-free care. This child is bubble blowing in an exercise, in a game. He's challenged to bubble blow 2 bubbles or 3 bubbles. And in the meantime, a blood sample is taking place. And this is a way how you can actually deal with the child so that it doesn't suffer when undergoing a procedure. So what is procedural distress actually all about? It's a combination of fear and anxiety, focus on the procedure, and pain caused by the procedure. And using this model, we can think of solutions, and we can actually give an overview, a framework of the kind of competencies and services we need to organize when we want to deal with procedural distress in children. First of all, pain caused by the procedure, pain-killing strategies, whatever they might be, are important parts of the strategy. Fear reduction strategies usually mean that a professional has to develop patience and has to slow down, respecting the interpersonal distance of children. Initially, children might might develop a lot of fear when you approach them too rapidly. They have this interpersonal space they consider as safe, so a professional should enter that space in a slow and patient way. Creating predictability by informing children in advance, desensitizing, allowing them to exercise before they undergo the procedure. And then the whole science about supportive language, using the right words, how to explain things to children without using medical terms and with words that actually create positive expectations. There's a whole science out there that actually we need to incorporate in our training programs of healthcare professionals. Second, managing the focus of the child during the procedure is actually a matter of directing the attention, how to distract, how to create interactive play, how to have a challenging task while doing the procedure, how to use guided imagination, how to use virtual reality, how to use medical hypnosis. And one of the references that you can check after this webinar with the QR codes that will be shown, I think, at the end, one is referring to a great paper on how to manage frightened children, and actually it's summarizing and explaining all these techniques and how you can become competent in this kind of modalities. And of course, sometimes children might need sedation. You have to organize it well. If the ophthalmologist is ready to do the examination while the child specialist is distracting the child, this needs a nice coordination between the child, the parent, and all professionals involved. You need personalized care. Every child needs a personalized, individualized approach. We should think about prevention of procedures. Is this procedure really needed at this moment? Is this child ready for it? Or should I postpone it to a later moment when the child is really ready for it? And then finally, don't forget, when we are done with the procedure, when the procedure is over, and for us it's over, the meeting, the encounter is not yet over for the child. And there's the unique opportunity to debrief, to reflect, and to create a memory for the next meeting. So that we shape the next encounter and try to create positive expectations. So to finalize, we have clustered now an international group of scientists and healthcare professionals coming together every 2 years to discuss opportunities to improve healthcare in children and to improve procedural comfort. And this conference the next one is in September 2026 in my hometown in Maastricht University. And we will have a whole workshop focusing on ophthalmological procedures as well. And finally, if you want to learn more about me and my work, there's the QR code to my inaugural lecture, and I'm happy to get emails from you with additional questions for any further question you might have regarding this topic. Thank you for your attention. It was an honor to be here, and I'm exactly within my 8 minutes, I believe, Ken. So I give the microphone to you again.
Thank you so much, Pete. There are so many pearls in that 7 to 8 minutes that it's remarkable. Thank you so much. On that note, I'm going to invite Morgan Livingston to speak, and then I know Sandra's going to conduct a discussion after Morgan's spoken. So Morgan, all yours.
Hey, everybody. I'm happy to be here, and I'm very excited that we are getting a chance to talk about this because it's something I'm extremely passionate about. There we go. Okay, so I'm Morgan Livingstone, a certified child life specialist, and my focus has always been the comfort, safety, and success of children and ways to increase their confidence with the eye exam experience. And this matters because we know, as Pete said, these eye exams can be really distressing for children of all ages and their families. And the specialty area that I focus on the most, retinoblastoma, means early infancy and in that first year of life when the child is diagnosed with a very serious illness. So this causes distress and fear in the family and can lead to lifelong impact of children's coping and their families coping with the whole medical experience. So I incorporate a lot of preparation in order to prevent problems from happening, to encourage families to cope better with the entire retinoblastoma experience. And that includes comfort positioning, lots of practice, and of course, a supportive presence, which can greatly reduce the upset and improve cooperation in children having eye exams, even infants. So you'll see in each of the pages that I'm sharing, there's a photograph of a child I've worked with that is exploring something related to the retinoblastoma experience. So here we have a little infant who's playing with a sedation mask, for anesthesia. And you can see that this child is just exploring it as an infant would, touching it, smelling it, exploring it, tasting it, and is not in distress, because we all know that children benefit from play and being able to explore their world at their own pace when they're not in the actual hospital. So through my child life lens, the key principles, of course, are really around that comfort, safety, and success that promotes confidence in children. So that includes preparation and education with age-appropriate language. Both Sandra and Pete mentioned how important it is that we adjust our language to the children that we're working with and their developmental level of understanding and needs. And in infants, of course, that also is an important part of the parent's experience, because the parent's level of upset or anxiety can translate directly to their child. So my goal is to prepare families, children, and their parents to prevent misunderstandings, misinformation, and trauma through play and practice. And you heard Sandra mention empowerment and choice is a really important aspect of this experience, because if we give a child a choice of, would you like to sit in the big chair by yourself, or would you like to sit on dad's lap? Giving a choice where there actually is very little choice, they're not going to have a choice not to do the examination, but they are allowed and afforded an opportunity to make a choice about what song they might want to listen to, or if they'd like to hold a special stuffed animal or toy. This family-centered approach to support and giving families opportunities to make decisions and choices for themselves that will help enhance and promote the confidence and comfort of their child during these eye exams, especially frequent eye exams, really can change the way that they feel confident and competent about each of the exams. Comfort positionings and strategies, of course, really work. And I'm a huge advocate for the play-based practice that promotes mastery, because if we can practice enough ahead of time, just like how children learn any of their normal life skills, then children can gain confidence and mastery. So in this picture, I'll describe as a little friend with retinoblastoma who's completed active treatment, but still having ongoing and continued assessments. And we created a toy MRI. So he's practicing the MRI experience with a medical play puppet. And as you can see in his beautiful doctor's coat, he's not stressed because he's experiencing and practicing and playing and preparing himself for these in an age-appropriate and methodical play-based way. So understanding the eye exam experience for infants too, bright lights, eye drops, physical restraint, and unfamiliar equipment can, of course, lead to things like fear of losing sight for children with magical thoughts. So we want to remember those different developmental reactions by age and group. So I'm not only a child life specialist, but I'm also an infant massage instructor. And I instruct families to do wonderful, positive, and engaging kind of reciprocal infant massage on the face to help babies especially gain confidence and comfort with the touching of their eyes and their face. So in this case, we have a little friend, Logan, here, who's under a year of age, and he's actually doing an eye exam on Dino, my dinosaur here. He's exploring with a toy that looks just like an ophthalmoscope, and he is, as you can see, not stressed. That preparation, that practice, and that play-based approach has allowed our little friend here to cope well and even mimic what he's been undergoing and he's been seeing in his own retinoblastoma experience. These child life supports in action really can create change. We do a lot of preparation beforehand, play-based approaches. Here we have another little friend. This is Lincoln doing eye drops and practicing eye drops on a doll. This with the prompts of reminding this doll to take a deep breath, to blink their eyes. And once she's done the drops, you can actually hear him in videos that I've created of Lincoln saying, "It's okay, Sonny, you can do this. Take a deep breath, blink your eyes," because they are learning. And again, that sense of mastery comes through. And after the exam, I encourage families to praise, provide a bit of recovery time, and of course, coping, because we want to acknowledge that this coping will continue throughout their life. Comfort positioning, as I mentioned, sitting on a parent's lap as a choice, holding hands in non-restraint mode, really encourages safety and cooperation, maintains a child's dignity, and really promotes connection and calm. The parents can help advocate for this, but the children themselves can do that too. And of course, medical access is our goal, but we also want to remember, as Sandra said, not to traumatize children. And we want to make sure that we create a positive experience here. I'm going to skip this if it's okay, guys, and we'll just continue on. But comfort positioning strategies extend into all ages. I love to adapt children's experience in lap sitting or side hugs, gentle swaddles or wraps for infants. Of course, if a baby needs to be laid down, we want to ensure that the caregiver is present and able to provide contact and comfort through touch. And of use of sensory supports, music, soft lighting, and toys always improves the experience when you're working with children. And that recovery cuddle post-exam, a wonderful positive way to ensure that children feel supported after an exam, is essential to that confidence, that comfort and safety and success that we are so desiring for this population. Here's a very tiny infant receiving massage after an eye exam. This one was a retinopathy of prematurity exam, and this infant has a soother. You can see that suck and swallow response that we use with sucrose. Of course, that sugar water has really encouraged this baby's coping mechanisms. There are many sample steps for the clinic day that are available online. I've put them in the chat here as well, but there are preparation books that go through the whole experience that help children understand the pre-visit, how to prepare and plan on their own, the arrival and what will happen during the day. As adults, I think we forget that we want to know each step of the way when we're going to the hospital or we're having an examination, and we need to afford that right and that familiarity of each of the steps to the children that we support as well. So pre-visit, during the arrival, and of course, during the actual presentation of the assessment themselves, children need to know what to expect. So encouraging them to bring their own comfort item, a special toy or stuffed animal, a blanket, whatever it is that a child needs to be and feel successful during this examination is important. And of course, distraction, talking about things. I know Sandra's very skilled at having conversations with children about the way they have explored their world, their school, their day, has functioned as a verbal distraction. And it's a wonderful way to ensure that children feel honored and cared for. Follow up, of course, we want to normalize and plan for the next time so we can encourage children to think ahead. I often will create a comfort plan, so a personalizable comfort plan that is available to children and families. But as I said, bringing a stuffed animal, a special blanket, playing a favorite song, or even singing a favorite song can really help children during the eye exam experience. Fidget toys and stress balls, personalized social stories and photos. You can use the existing photos that I have in my social stories and build on that and create your own. And the comfort plan is something to be shared with the team so that they can support that success of the patient. And wherever possible, involving a child life specialist can really make positive changes happen in the lives of children having eye exams. So our key takeaways, of course, are that child life's presence reduces distress and improves outcomes. Here's a picture of Logan, that little tiny baby that you saw here as a big kid with his magical prosthetic eye that helped the Blue Jays go all the way to the World Series this year. And also my other little friends working on prosthetic eyes through play. So I really hope that comfort positioning, that safety, connection, and dignity that we know promotes confidence and comfort is really where we're aiming. And every interaction that you have with the child is a chance to build resilience, and they need to practice. Thank you so much for having me, and I'm excited to hear the next speaker.
Thank you so much, Pete and Morgan. They were both incredible presentations and nothing less than what I was sure to entertain us all. While I wait to hear of any questions that are coming from the audience, I was wanting to sort of perhaps get a comment from you both. Some of the experiences that I have is when a parent comes out, I'm working really hard to try and get these eye drops in with all the positive language, and then the parent says, oh, it won't sting. And that's a lie. And I'm just interested in, have you got any pearls around how do I prepare the parent before they actually walk in the door?
Mm-hmm. I think that's a great question. I think, first of all, from my experience, you have to consider the parent as a full part of the diet what you're dealing with. The child and the parent are continuously co-regulating each other's emotions and each other's expectations. So if the parent behaves in a way that is not fitting with your intentions, then most probably this parent is either not prepared, is not understanding what he or she can expect, or just feels that he or she needs to warn the child. Or, and don't forget, many parents bring their own medical fear with their children. So it's not only preparing the child, it's preparing the diet. And how can they co-regulate each other's emotions? How can they be together competent? And of course, the parent might need different information than a child, but they should learn how they can collaborate with you, how they can practice at home, which words they should use together, so that these words are fully aligned with the words you use. And if you don't prepare them, they will use just the words that pop up and say anything, and that might indeed disturb your good intentions instantly.
Thanks, Pete.
I think a lot of what I do when I'm working with families too, and I think Sandra knows this as well, is I don't suggest pain. Even when you say it won't hurt, you're suggesting that there could be something related to pain, and pain becomes the focus of the child. We know that there are parts of the examination experience that might be uncomfortable. So I often talk about it feeling different. And a lot of the practice, the infant massage that we talk about on the face, the positive touch, is something that can be implemented throughout the preparation experience. But parents don't know what they don't know. They don't know that it is beneficial to their child that they practice this experience, just like they practice the alphabet and learning to use the toilet. They need to understand that preparing a child and allowing them to practice and promote that sense of mastery, gaining of skills, takes a lot of time in between visits in order to promote success. So we, as medical professionals, do have to take the time to educate families about the benefits, the developmental benefits of this kind of practice, even when you're not at the hospital, even when you're not in the clinic, because they don't know what they don't know. They just know that they are afraid of this experience, and they need us to help them understand how wonderful and positive it can be when you play through this experience with your children.
Thanks, Morgan.
Shelley, sorry, I'm just going to interrupt for a second. Shelley, I know you've done quite a lot of work on cycloplegic drops, right? What is your take? I mean, there are going to be people watching this, right, who are in India and have 200 children waiting in their outpatients, right? And there's a difference. We're a global organization. We want to talk about the regional differences. So it's different if you've got 10 children or 20 children or 30 children all day. You've got 200 in your waiting area, right? And they've got to be cyclopleged. So, Shelley, what's your take on that? What's the middle ground here?
Yeah, I think there's really two elements. What our team is researching here is around the administration of cycloplegia. I think what Pete was talking at is you've got the pain element. So, and that's where children have had previous experience with eye drops and do know that it may be uncomfortable or it does sting. But then you've got children who haven't got experience with that procedure and then have the unknown around the administration. And so you're trying to manage both of those aspects. So specifically around the sting, a lot of the cycloplegic agents are really low pH. So some of the work we've got a PhD student currently looking at is the formulations in more depth and looking at different the stability of cycloplegic agents at different pHs and whether that might be a way of just reducing the sting of the actual drop itself, but also whether different administration modes, so a micro drop, administering a much smaller dosage of the eye drop, looking at the efficiency of it in terms of cycloplegia and pupil dilation, but whether that also reduces the sting side. And even spray. And I know there's a lot of research that has been done previously around spray, closed eye, open eye, but just creating some more clearer protocols around that and looking at making sure that the drop is still doing what it needs to in terms of the cycloplegic effect, but at the same time, if the child can close their eye during the procedure, then that might obviously improve the overall, reduce the anxiety of having to have that drop. So that's some of the work that we're doing. Yeah.
There's a question, Sandra, from the audience. It says, how do you manage, and maybe Pete and Florin can answer this, anyone can actually, but how do you manage counseling a parent in a respectful way so that you're not threatening the child with the procedure? For example, if you don't sit still and have the drops, the doctor will give you an injection instead. You know, I have heard that actually. But I mean, I think we've all. I certainly have been guilty of it in the past. Yeah. How do you counsel parents and the child in a respectful way?
There's many things to say about this. I think it's a great question, and there's a lot of answers there. But I think one of the most important antidotes for fear is predictability, is creating predictability and creating the expectations, shaping the expectations. And you can do that in many ways, depending on the settings where you're working in. But anything that is not prepared, then parents might fill it up with any comment or with any reaction. So predictability is a key word in decreasing anxiety and having the feeling of being competent to deal with it. And I think that's already a first step. We just think that kids and parents come in as neutral persons that just are there in the office, but they come with a whole list of expectations which are aligned with what you're going to do or not. So shaping that is I think crucial.
Nicola, what do you do? I mean, I've been to South Africa. I've been to your amazing hospital in Cape Town. The waiting room is chaotic, right, at times, because you have so many patients. How do you deal with that?
Well, we do try and teach the parent. We definitely have parents threaten, for example, and you saw me smiling. We definitely have parents that threaten with the doctor. So we do counsel them against that. But I'm certainly going to be including a lot of these links that you're putting in the chat. I'm going to be putting that on our TV screen so that they can start watching them as they're sitting waiting. Another thing that we do is we send copy pages home with the parents to go and practice if we've had difficulty with them, for example, visual acuity testing and so on. So we do have a few tricks, but of course, after a session like today, we'll have a lot more.
Fantastic.
And just one comment that I wanted to make was, because I'm seeing the second generation of retinoblastoma survivors now, and I'm looking after their children, what I'm noticing is how triggering what I'm doing to their child is for that survivor. And I feel like I'm trying to fix, as it were, or manage the child and also that adult survivor. Because as I said, an anxious child does become the anxious adult. Does anybody have any comments around sort of recognizing what the parents are going through?
I definitely do that, Sandra, in my work, because I am working with multi-generational retinoblastoma families as well. We're working together with many of the same families. I think what I do when there's a threat, I wanted to just go back to that too, a parent threat for a child to stay still, is I think I mentioned in my presentation that a lot of child life role is correcting misunderstandings and misinformation. And so I playfully will correct a parent in front of the child. And then, of course, validate the feeling that a child would have. And similarly with our families that have had multi-generational retinoblastoma treatments, when a parent is noticeably upset, I think, Sandra, you've seen it, we have these very large groups that I offer for retinoblastoma families in worldwide conferences, guys. So it's a giant, 8-hour-long child life program for the day. And I include families, parents especially, grandparents especially too, because it's sometimes an entire family that's been impacted by this. So by incorporating them into the play and showing them, letting them explore the materials, letting them revisit, their experience in a positive, safe, and playful way actually can help families heal after, generations of fear and feelings of upset related to the eye cancer experience. So I validate feelings, though. I do that a lot out loud. If a parent is noticeably upset, I can say this can be really hard for parents, but we're making positive changes now so that we can ensure that children are confident and comfortable with this experience. And we see it. We're seeing the results of children that are coping well from infancy up to their, preteens and teens, because I'm that old and we've been providing the right kinds of support and ensuring that we prevent this trauma. Which I'm really proud of. I love to see and hear all of these incredible changes. And if we can just keep going, we can literally change the way this experience is for the next generation.
Thanks, Morgan.
So I think we have a couple of other, I'm getting information. Somebody said we found that face flushing and feverish feeling in the summers is more common with cyclopentolate. Is that just their experience, or do other people? I mean, I think if they get face flushing, that really does make the parents very anxious. Anybody had experiences like that? I mean, I have not found that the summer makes it worse, but if somebody's going to get a flushed face, they're going to get a flushed face, and we make a note of it. Anybody had any experiences like that? No. Okay. Well, it must be something to do with the summers where that person is. We still have a couple of minutes of the discussion. Can
I contribute something to
yes, of course.
Well, my experience is that when you really make a connection with the child before going to your examination room, I used to connect first and only with the child and not with the parent. And then I see that when I have a good connection with the child, the parents relax and they get confidence in the whole procedure. And then they will not say, well, if you do not do the right things, you will have to be something bad. But so that's really necessary. And I just connect in a good way with the child. And then you really you see the parents relax. Okay, this is going to be a good visit. Yeah.
I think, Rich, you're going to talk about this in your talk a little bit. The question is what do you do to the space to make it more comfortable and more relaxing for the child? And I know there is when you talk about the procedural testing that you do in your clinics, did you spend time with someone about the color schemes and about how the space looked to think about the children?
Yeah, there was when we built. So we used something called the Six Sigma method to build our entire clinic, which was come out of the Japanese. But we used the Children's Hospital personnel to help with this. So everyone who was going to participate in being in the clinic, including patients and their families, including the people that cleaned it, including the technicians and nurses, any educators, students, all had input in how the clinic was going to be built and how it was going to look. And as a result of this, the areas that are in transition from exam to procedure, from check-in to check-out, the dilating waiting area was a safe space. So nothing happened in the area where the patients were being dilated. The areas where patients had interventions, either examinations or procedures, were separate places and had separate designs. There were separate I'll talk about this a little bit, but there are separate instructions going into the procedures areas, and the family was prepared. Our feeling was the better the family felt, the better the child felt. And the analogy I use is the children are usually not upset being walked around the grocery store in their little basket while the mom is getting groceries, because the mom's not upset, or the dad's not upset, or the family's not upset. They're playing. But as soon as mom starts getting anxious and dad starts getting anxious and they're holding the child, then all of a sudden the child gets anxious. So if we could prepare, our emphasis was on preparing the family for this to be just another outing as much as possible, especially in the older kids.
That's great. We're running a little bit over, but there's a very interesting question that's come on from somebody who works in Pakistan, and she says it's not only busy OPDs, but it's also the level of education of parents. And that's just struck a note with me, because I have definitely come across situations where my regular diction, I'm like, they don't understand what I'm saying anyway in Pittsburgh because of my accent. But if I am speaking at a certain level on a standard, how I speak, there are some parents who don't understand what I'm saying. So I think that's a really important point. Does everybody agree? Trying to acknowledge.
Yes.
Yeah, Pete, go ahead.
Absolutely, I agree. Actually, in this connection moment where what someone spoke about already, it's not only important to connect, but also to understand in which words is this parent-child diet communicating about this situation, and then connect to that meaning and these words. And if there is a mismatch, there will be misunderstanding, there will be not understanding, and then that's a trigger of fear. So yes, that's up to us, I think, to learn to adapt to the language of another. And the language is not only cognitive language; is the way things are called, how they communicate with each other, and that's our challenge, I think, to deal with that.
Thank you. Look, this has been great. There's going to be more discussion.
I have one more tip. I have one more tip from our clinic. I know we're over time.
Okay.
But back to the drops issue. In our clinic, our drops waiting area is way too small for the number of patients that we would need to dilate. Number one. Number two, a lot of our patients have got very, very dark irises. So Cyclogel doesn't do it, especially if you're dealing with an accommodative esotropia. Number three, if you try and just use Cyclogel, you might not get the full plus that you need. So they need atropine. So more and more we use atropine. They get the atropine to take home. The dilatation is done at home, so that by the time you arrive for that day, half the clinic is already dilated. There's less screaming, there's less performance. It's a much faster in and out. Yes, they are then dilated for 2 weeks, but we have the correct script, which we need to do because we only have one option for one pair of free glasses per year. And that's how we've more and more we're managing this problem of dilating half the clinic, pupil dilation of half the clinic.
Okay, we're gonna move on. We'll move, Nicola. That's really excellent point. But we'll move on for the sake of time. And I those of you on YouTube, I promise you, all your comments I am going to mention. So bear with us. And I'm going to invite Florine, please, to give her talk on procedural comfort at Bartimaeus.
It's a real honor to share a bit about what we've been doing around procedural comfort at the Diagnostic Center of Bartimaeus. Bartimaeus is a rehabilitation center for people with visual impairments in the Netherlands. And our diagnostic center, we see about 1,200 children every year, many with hereditary eye conditions or CVI, and lots of babies and toddlers. Sandra already told her moment when she realized something had to change with the eye drops. And we had that moment too. In 2013, together with my colleague Helene Veen, we started a child participation project, and we asked children what their experience was with the eye exam, and that really opened our eyes. One child told us that he thought the drops were poisoned, and another believed the ERG wire was still in her eye years later, because we said that we would place a wire in her eye. We promised the children that we would improve 10 of the things they had mentioned, and the eye drops were number one. So we made an eye drop booklet, where children could choose how they wanted, on their mom's lap, right or left eye first, singing a song. Families loved it, but we were sad because there was no statistically significant improvement. Until Pete Laurel said, well, that's great news. It shows that it's not one size fits all. And he was right. You need a whole toolbox of approaches. The eye drop booklet is just one of them. Since then, we've been developing our pediatric ophthalmological toolbox, full of tools to make procedures more comfortable for children. For example, we made animations in several languages to explain the test, and they're free to download on our website. We come up with creative ways to help children to get used to the equipment in a playful manner, desensitization, and some of these materials were even sent to their homes in advance. We learned so much from Baruch Kraus, how to really connect with anxious children, and that's so valuable to us. We developed distraction materials to help children relax during procedures. And we made smart technical adjustments. So, for example, we can now make OCT in our clinic with all children, even the tiny babies with nystagmus. Working with procedural comfort has brought us so much, and I would love to tell you more about it. Children experience less fear and stress, and we can do higher quality exams even in the youngest children. I wouldn't want to go back to how it was before. If you're interested, many of our materials are free to download, also in English, Turkish, and Arabic. And I will now, I stop sharing.
So, Florian, I'm just going to interrupt because I got a message
Yes.
from Pete to say that he's been called away to an ICU emergency. So, Pete, are you still there? Before you go, we understand this is the life
Yes.
of a medic. I was going to ask everybody at the end, what is your one take-home message? So I'm going to ask you to do that because I know you might have to leave for this emergency. So for your one take-home message from this webinar, from what you have to say to the pediatric ophthalmologists, orthoptists, optometrists listening, what would be your take-home message?
Yeah. My take-home message is that actually I have two. First of all, establishing trust in children is a skill set. So it's not an intuitive activity of those who think they can. Everybody can learn it. Second, the quality of care at the short term and the long term improves substantially if you just connect with children before you go to the medical content. So just a small break, 1 or 2 minutes, is usually enough to make a huge change of practice. So these things are my core messages, Ken.
Thank you. Thank you for being with us. I hope you can join back. I hope the emergency is not serious, but we fully understand. So, Florine, back to you to introduce our next speaker.
Yes. I want to introduce Nicola Freeman. So the floor is yours, Nicola.
Good day, colleagues. I work in a busy pediatric eye clinic in Southern Africa, and we care for children and families from a wide range of cultural backgrounds. With limited theatre time and a heavy patient load, we've had to find some practical ways and creative ways, and I'd like to share a few of these insights. Some of them are quite simple strategies. Comfort during procedures is a universal need, but the ways we achieve it differ depending on resources, culture, and context. Procedural comfort is not a luxury or a high income settings. It is possible everywhere, but strategies may need to be adapted. It is essential to appreciate that in order to accomplish procedural comfort, the building blocks need to be in place. The emotions of the parent and the child, as we've said so often in previous talks, need to be managed as best possible, but from the very, very first encounter and then every encounter thereafter. Because if you don't do that, the anaesthetist's challenge becomes greater. Thus, every single step in your examination should take the child's psychological safety into account. For example, just playing a game of peekaboo over the shoulder of a parent can turn the entire examination into a game. In many cultures, back carrying allows the mother to soothe and protect their infants. And the entire examination can be performed with the child safely strapped to the back. Many times we do the entire examination on the back. And in some cultures, breastfeeding. Breastfeeding in public is considered entirely acceptable. In our setting, it is often possible to do the whole examination with the child attached to the breast. And I recommend that when parents or mothers are not comfortable with public breastfeeding, a pediatric ophthalmologist should consider discussing this option as a possible approach to getting some of the examination, if not all of the examination, done in this way. Desensitization and conditioning babies can definitely be considered. It is normal for a child to not be comfortable with being touched in the face. Now, there really aren't many direct randomized trials specifically testing behavioral conditioning for acceptance of rebound tonometry, for example. But there are many studies supporting the feasibility and improved cooperation for other procedures. This 5-day practice routine can be used to condition a child requiring repeated rebound tonometry. For the first 2 days, the parent is told to gently touch the face, the cheeks, and the forehead. And then the eyelids are gently stroked for 2 days, 2 to 3 days, followed by gentle lifting of the eyelids, playing a game of peekaboo. And finally, the eyelid can be lifted and fixation target held to distract. A similar routine can be used to condition a sleeping baby to not wake when gently touched on the eyelid. So in our setting, certainly in my pediatric glaucoma clinic, where I need to do serial intraocular pressures, many examinations under anesthesia have been avoided by using this approach of desensitization and conditioning. Of course, the aforementioned approaches do not always work for all babies and children. When I visited Moorfields Hospital some years ago, I was struck by how remarkable their follow-up was, and by how frequently the children, especially those with pediatric glaucoma, were brought to theatre for examinations under anesthesia. Now, such a high level of continuity is not always possible when in certain situations in certain countries. And it's only possible when procedural comfort is very well established. The reasons for poor follow-up are multifactorial in our unit, spanning every level of healthcare journey. And this table provides an overview of the key contributors to our poor follow-up in some units. And it's from health system limitations to socioeconomic pressures such as travel, the long distances, the disease-related issues such as frequent examinations under anesthesia and multiple surgeries are what wear even the most diligent families. They wear them down emotionally and practically. But of course, the most important in any healthcare system is this procedural care. And it's the most important contributor to poor follow-up. And back to the UK in Moorfields, in London, the reason they were able to do that kind of follow-up and be back in theatre every month was because of topical anesthetic cream. And the use of this for placing IV line was pretty standard. It was highly effective in improving procedural comfort. However, in our setting in Southern Africa, the use of anesthetic cream is not always feasible. The creams are not always available, and the anesthesia team often lack the necessary human resources to implement this approach as a routine. For this reason, Christine and anesthetic colleagues at our institution performed a study to establish an anesthetic protocol for pediatric glaucoma patients requiring examinations under anesthesia. And accurate measurements of intraocular pressures is, as you know, essential in pediatric glaucoma management. And with the children requiring serial measurements and examinations under anesthesia, the most and we know that most anesthetic agents reduce intraocular pressure, we needed to understand the ideal time to measure intraocular pressure under anesthesia, and as it was questionable. So the protocol involved an induction with sevoflurane, followed by intravenous cannulation with a bolus of 2 milligrams per kilogram intravenous ketamine and a 4 milligrams per kilogram per hour ketamine maintenance for 15 minutes. The intraocular pressures were measured in 50 eyes of 25 children, and the intraocular pressures were recorded from 2 minutes after the ketamine bolus, and then every 2 minutes until 10 minutes, and then again at 15 minutes and 20 minutes. The physiological variables, including heart rate, intraocular pressure, mean blood pressure, and systolic blood pressure, were recorded over time. And these essentially returned to baseline at 8 minutes, which correlated with the recorded sevoflurane elimination. The mean IOP after sevo induction was 3.68, lower than with ketamine maintenance after 15 minutes. Contrastingly, the difference in IOP between ketamine anesthesia at 15 minutes and near wakefulness was only 0.28 millimeters per mercury. Thus, the IOP lowering effect of sevo is essentially reversed at 15 minutes after the discontinuation of the inhalation gas. And that's when the anesthesia is maintained with an intravenous ketamine infusion. So the IOP measurements appear to stabilize at 15 minutes time point until the point of near wakefulness. The limitations of the study were the absence of the wake intraocular reference measurements and the small number. But this protocol may well be useful in settings where intravenous access under topical anesthetic creams is not available, or you haven't been able to achieve it using the topical creams, and when intramuscular ketamine is needing to be avoided. So, sorry, I was stuck on that previous slide. So in summary, apologies, so there's my slide. So the sevo slide. In summary, procedural comfort starts at the very first encounter with the patient. Emotional security and psychological safety may differ culturally, and desensitization and conditioning may help reduce the number of EUAs. And sevoflurane induction, followed by ketamine infusion, is a workable option for glaucoma management in our setting. Apologies, I didn't move the slides on. There is the article that I wanted you to bring to your attention.
Thank you very much, Nicola. I would now like to introduce Rich Hurtle on preparing the paediatric patient and family for special testing of the visual system. Thanks, Rich.
Thank you. I assume everyone can see my slides. It's a pleasure to be part of this webinar, and I hope that this can summarize. Some of this is redundant and maybe can summarize things that have been said before, because I think that this has been very thoroughly covered. The unique experience that we have with patients who have traveled all over the world to see us for special testing is that we've incorporated most of the available special testing in ophthalmology that adults undergo routinely during the pediatric exam. And you can see them all listed here. And so patients will spend up to 3 to 5 days with us, depending upon how long after surgery. So many patients that come in from out of state or out of the country will come in for a full evaluation and treatment. And they'll have all of this testing done over a 1 to 2 day period, as well as have surgery done, and then be seen post-operatively. So it's kind of a medical vacation, for lack of a better word. And so preparing the family for this trip is probably as important as preparing the child, if not more important. So some of the things that we've learned is really about preparing the family. Over the decades that I've been practicing and had practiced, I noticed, and it's not unusual, I think all of us have noticed, that there's a change in how the parents and family are involved in the child's care, to such a point that they come in with all types of preparations from all types of sources. And in our situation, they often come in with multiple opinions, as well as online resources and questions, so that the family is arriving with a lot of anxiety. And as I said before in the discussion, I think that that's sometimes transferred down to the kids. So we try and prepare the family as much as possible. This is a clinic in India, and this is my grandson, who knows me very well, and after a few years trusted me to do an indirect exam on him, but it even took a while with him, and I see him all the time. So it really does take a little bit of work, effort, and time to prepare this. Our goal is to try and get information. Our goal is to get data from the family as well as from the patient that's both valid and that's reliable. In other words, when I get it on a second or third or fourth time, it's repeatable, and it's something that I can use to make medical decisions. This can't be done by one person. It would be unusual for the treating physician to be able to gather this information. In our experience, it really requires a huge team approach. And we have to understand where the child is socially, where the child is economically in the family, where the child is emotionally, whether they have special needs, whether they're on medications. Those are the kinds of things we need to know so that we can complete the testing. How'd they do on the previous test? We had to arrange our schedule of testing so that it would be done in a manner where the hardest tests were done last. This is an extreme situation. I was in an operating room in India, and the kids would come in and get retrobulbar anesthesia right there from the anesthesiologist, sitting in the operating room without their parents or everybody. And I haven't seen this in the Western part of the world, Asia. And here's a little child getting a retinal examination. So for us, it's really, there's a lot of emphasis on educating the family, and it begins with the call into the hospital and to the clinic. And we asked the family to find out this information. We've prepared written information. We prepared online information they can go look at. We've actually even asked them to get in touch with grassroots organizations of the diseases they study and the reason that they're seeing us, so they can find out from other families and parents what the experience was like and what they expect when they go to the office. I think it's important for all the personnel to enjoy what they're doing. We only hired people that really wanted to be around kids and families. We hired people that were warm and compassionate, that people that had an ideal nature to them about the care of children, because these are the people that were going to be interacting with our families. There are most of us get a sense of what it's like for a child, and in pediatrics, it's unusual. I was just at another conference recently, and I forget that in the adult world, the first question they don't ask is, what's the age? But we, in the pediatric world, before we want to know anything else about the patient, the first thing we want to know is the age of the child. And I think in preparation for a procedure or a visit or an interaction, we have to, our frame of reference is always the age of the child. I'm not going to read these on the slides to you. I think that you'll be able to see them yourself. This is actually a family of 4 I took care of when I was in Pittsburgh, from when they were in the unit, and now they're in their late teens, the quadruplets for ROP. So this is generally the age-specific strategies, and I know this has been said much more elegantly by other speakers in this webinar today, but generally, the little children need less direct attention prior to the intervention or the procedure, and the older children need more discussion, as well as more discussion after. I think what used to be called a debriefing and now is a post-procedural talk is really important with the professionals. So what we used to do was after the testing was done, the technicians who worked closely with the patients would say, the testing went well, we got some really good results. The technician, the doctors and nurses that are working with you will discuss these with you after. And so we made it a point to discuss the results at a separate time when the patient was comfortable and the family was comfortable and the testing was over, and we got time to sit and discuss both the results and how they felt about the testing. Always talking about the patients always wanted the results first. We went back and forth. Should I ask them how they feel about the testing? What was it like for them? No, they just want to always know. The family wants to know the results. So we would go over the results and said, what was that like for you? How could we make it better or worse? And we also had a post-exam questionnaire that the hospital developed for us that they would send out. These things have been said before. I think physical comfort and distraction are really important, even up to and including sedation. When I was a young staff person at Children's Hospital here in Philadelphia, we used to give in-office waiting room chloral hydrate. And about 20% of the kids overreacted and got really hyper. About 20% of the kids, it didn't work at all. And about 60% of the kids provided some ability to do some of the exam, but not the whole exam. So that it seemed to help, but we certainly can't do that anymore. And now we have observed sedation units where we can do that. I think it's important for us to understand how to try and interact with the kids' feel. And sometimes it's not necessary for us to intervene, but just to allow them to express their emotions and allow them to feel the things they need to feel. We get help with restraint if we ever need restraint for any reason, especially in some of the developmentally disabled kids. They can hurt themselves or the people around them. I've been bit a few times by children, so I think there is a time that's necessary for restraint where you don't need to put the child to sleep just to put drops in them. And so we have hospital assistance with that. We have protocols for restraint that we used both in the outpatient and the inpatient setting. I'm sure that many of you have these as well. And the aftercare rewards are really important at every age. Even adults like to get rewarded for cooperation. Talk to them about how they feel, especially the family again. And we always would bring the kids and families through the system, through the physical plant, in some way, shape, or form, whether it's online or actually physically there in a small tour before they actually were introduced to all the rooms. They would see the room. This is the room where this is going to be done. This is the room where this is going to be done. And so the more that they saw those, the less fearful they had, because things are always worse in our minds than they are in reality. So we tried to present them with a little bit of reality. So in summary here, I think it is important to be honest, and if there's going to be some discomfort, it's important to relay that in a compassionate way. It's important to understand that the feelings of the family and the parents are as much of an issue in getting reliable and valid data as it is the child's support. I think it's important to present clear and accurate information, and it's really that there's no way that this gets done in children without a group of people working together with the same goal in mind, to get information from the child so that we can care properly and make good decisions, but while maintaining our attention to the child's needs, their emotional and physical needs. So I think that kind of summarizes how we've done things and also reinforces what's been said throughout the webinar. Thanks for letting me participate and sharing some of our experience at Children's Hospital.
Thanks so much, Rich and Nicola, for those presentations. So we are running a little bit over time, but we do still have time for some questions. And I'd like to open the floor for those questions, but there's one in the chat that's come in earlier about how to ensure medical students, residents and fellows join in the clinic approach and not undermine the process. Who trains them before coming, and what about other new staff? So do we have any comments from the panel around that? When and how do you do it?
Well, we have, I think that most of the people in the educational environment have fellows, students at all levels working with them. We have postdocs and scientists who are not normally used to working in a busy clinic situation. So they all undergo the same orientation, hospital orientation about interaction that the docs and nurses and front staff go. So whether they're there for a week or 2 weeks, most of them spend a full day getting in having the HR process so that they're introduced and they understand how things work. And then I think the person that they're working with, whether it's a technician or whether it's one of the docs, comes in early with them and spends time discussing what's important. But it's mostly until we feel comfortable with the person being educated, they mostly are observing and shadowing. We really have, I think it's more than in the adult world. We really don't let it, even the fellows trained as a resident, we don't let them near our families and patients close enough. You know, they don't take care of them directly right away. They're not, you know, being the first surgeon. So there's a period, I think, of absorption into the practice with trainees that's delayed compared to the adult world.
I think that's a difference between people who work in a children's hospital and people who work in an eye institute. A standalone eye institute, there is a definite difference in approach, and I've noticed that. Sandra, before we ask questions, just a few things that a lot of people have been putting comments in. Firstly, we have now people from Honduras, Guatemala, Peru, Canada, South Africa, Nigeria, Egypt, Kenya, Tanzania, and Mexico listening, so that's fantastic. A lot of comments that people have made, I don't want them to feel they haven't got a voice. So at Sick Kids, apparently they use bravery beads, and as they get braver, they manage to make a bracelet. People have an eye diploma that they give to children. Animation movies are a big hit as well. And in the links that we have, there'll be options to download those, you know, treats and stickers. Interestingly, 3 comments. Somebody says having a fish tank in the waiting area can be very calming for children. That is true. And the same person also soundproofs their clinic room so that the child waiting in the other room can't hear the first child screaming when you put drops in, which I think is a great idea. And then somebody else says that they've given all the clinics in the children's hospital an animal name. So if you're going to ophthalmology, for example, at Pittsburgh, you're going to Penguin Clinic, which I think all are fabulous hints. And people also examine parents before they examine the child so that the parents can say that it doesn't look, it's not so bad. There is a question about ROP exams and how that affects babies. Anybody got any comments about ROP exams? And yeah, go ahead, Morgan.
I did a lot of research on this many years ago. I feel like when I'm dating myself, I think it was maybe almost 20 years ago, but the preparation and education for the parents, I felt, and we proved in our research, was essential to helping them be confident in providing comfort measures for their baby. So it is very common for ROP exams to take place strategically when a parent is not around, when a baby is in the NICU or staying in the hospital. But our research proved that if parents are present even in the room to give verbal support to their baby and maybe a comfort measure like swaddling the lower half of the baby and ensuring that the baby knows that the parent is present because they're the #1 tool for that infant to cope, we noticed measurable calm in babies receiving ROP exams. And of course, the use of sucrose, you know, we want to always promote non-pharmacological pain management strategies for babies because we know, although you could quickly get that presentation, you know, of the eyes done, by holding a baby down, we know that there is a very longitudinal impact on that baby's ability to cope with future painful procedures if we don't provide the right support. So educating parents, including them and being respectful of the parent's ability to participate and provide comfort measures was the #1 takeaway from the research, that if they're not educated enough about their ability to provide comfort to their baby, they typically disappear from that process and the baby does not cope well.
Florian, can I bring you in and Shelley in on this question? Sometimes you'll have a child that you're seeing for the first time, but they had a really bad experience with drops at another institution. They were held down, the drops were put in, and the child comes in, and the first question the child says is, "Are you going to put drops in my eyes?" Right? So they're already anxious. It doesn't matter how much education you've given them in the waiting area. They just remember what happened last time. And I have seen children physically get worked up and I think they're going to throw up, right? How do you deal with that?
Well, Sandra?
No, we're going with you, Florin. This is for
Okay,
you.
okay.
You and Shelley.
Yeah. Okay.
And then
Yeah.
we'll get the ophthalmologist involved.
Yes. Well, it depends on the age of the child.
It's 6 years old. 6-year-old.
6 years old. Yo. Well, I first want to make a connection with the child and leave the question and first do the other things of the examination and try to build some trust. And maybe we can talk about the procedure after, because how and try to find out what is unpleasant for the child. Most of the drops are putting in, well, just open the eye, put in a drop. You can also give the drop on the eyes when they are closed, and then they can wrap with their hands, and then the drop is also already there. So I think I will I will do it that way.
Shelley?
I agree. I think it's been said a lot, but the connection with the child, making the child feel safe in the space. So a lot of game playing, spending time, important time early, getting the child on side and feeling safe. So we use a lot of different toys, fidgets, things that there's amazing fidget toys that just work as good distractions for the child, but also really not kind of skirting around the topic of what might happen at the end. So being open and honest and validating that child's emotions and the stress that they're potentially having, and also from the parent as well. So just recognizing and creating space for that conversation to be had.
If I can just make a comment. So I've got two things that I say to children. One is when they tell me they don't want to have eye drops, I tell them I don't want to put them in, but we both have to do something that we don't want to do today. And the next thing that really breaks the ice is I just tell them I'm the best eye dropper in the whole world. And I think that that helps me. Gives me a little bit of confidence that I know what I'm doing, and I'm going to do my best to do the best job. And that creates a little bit of laughter, and I'd say, right, we're going to be a team, we're going to get these in and we're going to do it really well, and it's not going to be the terrible experience they feel that it's going to be.
Rich, sorry.
So the 6-year-old who goes apoplectic, I feel we can make them calm, but when it's time to put the drops in, they often go apoplectic again. So I know we're talking, I don't believe that we can make all these kids cooperate. I don't care how good you are, how confident, how much connection you have. There are going to be kids, and many of them, I would say, Max, thousands, tens of thousands of children getting dropped that are just going to fight. And unfortunately, they're going to have to have some type of gentle restraint, a hug by the parents or the family. And so I don't want to give the impression that it's going to be a pleasant experience, no matter what we say or what we do or what environment we provide. When the drops go in, it's still going to be unpleasant for most of the kids. I don't accept the fact that we have the ability as a human race to make that process not a problem for a lot of children. It's going to be the act of putting the drop in is going to be an issue for most kids. It's what you're doing before and what you're doing after mitigates that. And I just want to be honest with that. I don't feel like there's a magic solution to allow children to allow us to put the drops in.
Yeah, I think that's a reasonable point. But I think that's why I was so glad Morgan talked about comfort positions. I think the comfort positions are so important and engage, at that point. So what I actually, before I go on, Nicola, anything to add on, or anybody else?
I think I want to challenge that statement only because if we know that it takes time for a societal change. So we could, if we continue to implement all of these incredible ideas from all of these incredible experts today, we can actually change the way children experience this. If we teach families about their participation in practice, if we teach children improved coping strategies, like all of these things build upon each other to ensure societal change. So we used to not even let parents come to the hospital. remember when children were hospitalized and parents were not allowed to visit them? We've made monumental changes in the last 100 years. And now we know that children's coping is actually supported and improved, and their overall healthcare outcomes are better when the caregivers are included at the hospital in the child's care. So we made a big change in the last 100 years. I think that this change, helping children participate and gaining the skills and the confidence to have a better eye drop experience, is a much smaller change, but it is something that we can do significantly over the next few decades. And I feel confident that we can make it so that there are less children that are distress rich when they have their eye drops, because we've provided the skills, abilities, the practice, and also their own autonomy to put the drops in themselves. I think that we can get there.
I think you're absolutely right. But I mean, there is the moment between here and next or there is still that bridging gap. And I think what Rich is saying is that we don't want people listening to this blowing us off and saying, oh, they're living in cloud cuckoo land. I agree with you. I agree that it is definitely, my practice has definitely changed.
Oh, yeah.
And it's my children, I mitigate their anxiety much better than I ever did. But again, it's not zero discomfort. So I'll just tell you what I do. If I have a child like that, I just stop and I ask them what their favorite place in the world is. And it's normally their bedroom. And I ask them to start describing their bedroom to me. And as they do that, you can see their anxiety level coming down. And then I talk to them about whether they've been in their bedroom and they ever got any dust or anything in their eye. And the majority of children did get something in their eye while they were playing in their bedroom. And I say, well, that something similar is going to happen like that with the drop. The other thing we've started doing is we use fluorescein in lignocaine. It's a compounded drop. It does not sting because of the pH. And so I tell them this is a magic drop. They've never had it before. We put that in. It doesn't sting. And then they allow me to put the second drop in. And that has really made a big difference. So I think, Rich, I take your point completely, but I agree also that we have to change.
I agree with Morgan in that, but if we could make the drops painless, that would be the biggest single step. Because no matter what we do to mitigate pre and post, if it hurts the child, and you probably had drops in your eyes, Morgan, it's very painful to have, and so the kid is not, if we can eliminate the pain of the drop, the physical pain, that I think that would be one of the single largest additions to making this seamless, this procedure not such a big deal. So I think that's what's getting in the way a lot of this, is actually the physical pain of the drop.
But
So
also,
Yeah.
Go ahead.
I think the pain is a small element, because the number of children who have this response of not wanting the drops, and it's their first experience with drops, so they don't have that history of the pain. So again, that's the societal change that with time, as we're desensitizing and making families aware that there is less pain, it will take time. But you do have this proportion of families or children who've never had the drop, and it's still a challenging procedure. So the pain is one component, I feel.
Yeah. Well, it's also very important that when you immediately, after a painful procedure, when you immediately distract the children, there is another way in which the child remember the procedure. And we also, when I give a compliment to the child, I do not say, well done. I really point what they did to make the procedure successful. So I give meaningful compliments, not just good done, good boy. No, because you sit with your chin on the chest. I could make very nice pictures, and the ophthalmologist knows exactly what's inside your eye. So that really makes a point, and that also for the children. So it really is necessary to do the right thing also afterwards.
So I think this has been amazing. I mean, I hope just to give you an example. When this webinar was advertised, I had a very famous pediatric ophthalmologist, really famous pediatric ophthalmologist, reach out to me and said, is this about ergonomics for a surgeon? I went, no. It's about the procedural comfort for the child. So the fact that pediatric ophthalmologists, some of them don't even know what this means that we have to get the word out, make sure they see this this video. Look, there are some amazing comments in the YouTube channel, and it's impossible for us to cover all of those. But when you tell people that to watch this webinar, those comments in the chats will be there. Some great distraction methodologies. What I wanted to do now to start to wrap up is ask every one of you, like I did Pete, what is the one, if there was one message you could leave, like an elevator pitch to the audience, what would it be? And so who would like to start? I'm not going to pick on anyone.
Mm-hmm.
All right, I'll pick on someone. Morgan?
You can always pick on me. I wanted to say that a lot of, implementing this takes bravery because it's new, it's different, it is childlike and child-focused. So I encourage everyone to be brave, be silly, have fun with your patients. I love that we're really promoting connection with our patients with these comfort measures for children and their families. And I promise you that if you implement this, children will be confident and comfortable with this experience because you've been brave enough to implement something different. And it will take time, but I believe in the importance of play in children's healthcare. And I'm really proud to be able to be here with all of you and share our strategies.
Thank you. Shelley?
Yeah, I think it's important that you're your child's advocate, be your child's advocate, listen to the child. Just because something has always been done a certain way doesn't mean that's how it has to continue being done, and educate yourselves. And yeah, I think this is a really important topic.
Rich?
I emphasize that the attempt to include the parent and caretaker and to reduce their anxiety, because I really do believe the connection between their emotions and the child's emotions are so direct and intense that the more we can reduce the family's anxiety, the easier it will be to use all of these approaches with the patient.
Nicola, before you give yours, I just wanted to make one point. I used to use ketamine before I worked at Sick Kids and Great Ormond Street. And the anesthesiologist there hated ketamine because it's associated with nightmares. It's a very well established link. So for those of the people listening, I just want them to make sure their anesthesiologists are happy to give ketamine before they give, if they decide to do that. Have you had experiences of that with your children?
Well, what option do we have other than that for the intraocular pressures? If we cannot,
I know. So I think it's a balance.
So in my mind, the procedural pairs, not just from the first and the second and the third examination, it's right through to the repeated. But for me, the children that are suffering the most are the ones that are going to theatre repeatedly.
Of course.
And
sorry, so I didn't mean to hijack you there.
No. That's to me. That is probably the biggest issue. Is those children that have got basically traumatic stress from going to theatre,
of course,
and finding skill, working on those skills with the anaesthetist to make sure that that's not too traumatic. As you heard, with the problem children, we deal with them by sending them home with the drops and making it mom and dad's problem to get the drops in, because we don't have the numbers and the capacity to entertain them at work. So they go home with their drops, have their drops put in, and arrive with their pupils dilated already. But it is definitely important to train the parents how to do this properly, so that it doesn't become a traumatic experience. Because we've been discussing mainly cycloplegia, but what about the patient who needs regular drops every single day, morning and night, for their condition, whether it be glaucoma or BKC, vernal keratoconjunctivitis? These patients need to have drops every single day. So all these tips that have been given today are very, very useful And I think it's important that they are shared with the parents, because we have an encounter once every few months with these patients, but the parents need to know how to follow through for those that are on treatment. So that's my.
Thank you so much. So, Florin, Sandra, take home messages.
Yes.
Lauren, you go first.
Yeah. If you think you're doing well, just ask the children themselves. And I'm sure they'll surprise you with their answers, and they help you to become even a better professional. That's my take-home message.
Fantastic.
Well, I'm going to use Angela Mayu's words: do the best you can until you know better. Then when you know better, do better.
That's very, very appropriate. I want to thank everybody. I hope you can see these links. These are links you may find important. If you don't get them right now, don't worry. This will be on YouTube, so you can pause the video. I think all of these are excellent. And I also managed, although I didn't get the QR code conversion, Morgan, these are the two that you gave us. These are links for booklets that you all may find useful. I genuinely want to thank everybody for your presentations today. I encourage everybody who's listening and everybody and the panel, of course, themselves, to let your networks know about this, because this will be on the WSPOS channel. It'll be there forever. I think this is so important, just to have raised the issues. There are some things I want to run over. There's some future events. We've got a webinar in conjunction with the Young Ophthalmology Society of India, but it pertains to young ophthalmologists all over the world. We have a WSPOS subspecialty day coming at London on the 11th of September, 2026. Now, WSPOS 6, the World Congress, is going to be in Cancun in Mexico, May the 13th to the 15th, 2027. Sandra Staffieri, you are going to be there.
Okay.
I'm joking. I want everybody to put that in their schedule. And I'm going to talk about a couple of surveys. The myopia is a big deal. That we have this consensus statement. We have podcasts. It's on the website. These are the links if you're interested and in listening and reading this. This is the flyer for the World Congress. The one in Malaysia that we had was extraordinarily successful. We expect this to be even bigger, and there will be at least one session on procedural comfort, and I'm sure it would be good to see some of the speakers there as well. Now, we are coming to the end of the biggest global survey on pediatric intraocular implantation ever done. It closes on the 31st of December. There are going to be the 5 winners that we picked randomly will receive free registration to WCPOS 6. Go to the website and please take the survey and spread that amongst your colleagues and your adult cataract surgeons, because they do pediatrics as well. So let's get their input too. One thing I want to talk about, the Alagille syndrome. It's a rare disease, Alagille syndrome. They're doing this amazing survey that's going to go out to all our members. Look out for it. The world map just shows where we have centers that have acknowledged that they see this rare disease, but look out for that as well. So membership, remember, for WSPOS is free. It will always remain free. So please join, and then there are all these benefits. And lastly, David Granite runs a listserv, free to join. You can follow us on social media. I want to say a big thank you to Entod Pharma, without whom we wouldn't be able to do these webinars, and to Caroline Brick and Kate Plassen, who are our management and admin team. On that note, I want to say massive thank you to Florin and to Sandra, and a massive thank you to our panelists. Jagrat Lalu, when I see you, you owe me at least 7 beers because you slept through this, but I don't blame you because it's 3 a.m. in the morning. I would have done exactly the same thing. And Pete, I hope your patient is okay. Thank you. Good night, good evening, good morning, wherever you are. And there's Sandra upside down in Australia. Thanks very much, everybody. God bless. Have a great day.
Bye-bye.
Bye-bye.
Have a great
Thank you,
weekend.
Ken.
Thanks,
Bye.
everybody.
Bye.
Bye.
Thank you, everyone. That was amazing.
Yeah.
I think we might still be live.
Oh.
I think